Hello, my name is Taryn Haney, and I am a second-year internal medicine resident at Oklahoma State University Medical Center. Today, I will be presenting on a case of bilateral coronary-cameral fistulae. Patient information has been removed to protect the patient's privacy, and all identifiers have also been removed. Coronary fistula are a rare phenomena having less than 1% incidence. Even rarer are those cases possessing multiple fistulae concomitantly. Fistulae are divided into two groups: congenital, the most common, and acquired. Congenital fistulae are thought to be persistence of an embryonic intratrabecular vascular network, while acquired cases are often related to iatrogenic causes, such as via vascular interventions or procedures, traumatic, such as laceration or chest injury, or spontaneous, such as secondary to myocardial infarction. Most fistulae originate from the left side of the heart and drain to the lower pressure system of the right heart. The most common origin is the left anterior descending coronary artery, while the most common drainage sites are the right ventricle, right atrium, and pulmonary arteries. Many cases are asymptomatic and found incidentally. However, as seen more often in cases with multiple fistulae, anginal symptoms may occur. These symptoms are thought to be secondary to a Steele phenomenon, producing inducible ischemia. Blood will flow from the higher pressure left-sided system toward the low resistance of the right heart. Risks of these fistulae include myocardial infarction, heart failure, arrhythmia, aneurysm formation, and endocarditis. Given that many cases are asymptomatic, fistulae are often found incidentally on left heart catheterization, which remains the gold standard for diagnosis. However, emerging cardiac imaging have been utilized for further characterization, and management largely depends on this characterization. Size, origin, and patient factors all impact treatment decision. Current guidelines recommend consideration of surgical or transcatheter closure for large fistula. Those with small or moderate-sized fistula are considered for closure based on symptoms. The patient in this report came into outlying facility reporting gradually worsening shortness of breath and generalized weakness over the last few weeks prior to her arrival. She had no known past medical history other than use of methamphetamines. She was noted to be hypoxic on room air and was placed on supplemental oxygen with improvement of her saturations. Initial evaluation did reveal a BNP of 407. Chest X-ray was concerning for edema consistent with her BNP. Troponin and thyroid labs were both within normal limits. On arrival to our facility, she was started on IV diuresis with significant improvement of her oxygen requirements. She was able to be weaned down to room air. An echocardiogram was ordered and confirmed suspicions of new-onset congestive heart failure with an ejection fraction of 20% and grade 1 diastolic dysfunction. For further evaluation of the etiology of her heart failure, left heart catheterization was performed. Her heart failure was noted to be non-ischemic in nature. However, she was incidentally found to have bilateral fistula. A cardiac CT was then performed, revealing one fistula originating from the left anterior descending artery to the main pulmonary artery, and another originating from the right coronary artery to the left main coronary artery. Given her heart failure, this patient was started on guideline-directed medical therapy, including metoprolol and valsartan, with up-titration as tolerated on an outpatient basis. It was also recommended that she cease all recreational drug use. She was encouraged to follow up in the cardiology clinic for repeat echocardiogram in 3 months. However, as of this presentation, she has not yet done so. Given the characteristics of these fistula in this case report, surgical closure was not conducted. This case does point out the importance of emerging cardiac imaging in characterization of cardiac structure and function. As cardiac imaging continues to evolve, and find its place in screenings, incidences of structural varieties may arise, underscoring the importance of knowing of such varieties. References utilized in this report are listed below. Thank you for your time and for your consideration.